This is Barry Servette. I'm the medical director, and John Strauss, our founding director, is here. And we are delighted to welcome everyone to our clinical conversation session today. As you know, it's scheduled for the fourth Tuesday of every month. And so the topic for today is the rollout of the MCPAP anxiety disorder algorithm. We're looking forward to a nice discussion. So a couple of housekeeping things before I introduce our speaker is that we are recording the session, and it's going to be available on the MCPAP website at www.mcpap.org. And a copy of the slides are going to be available on the MCPAP website on Archive News and Webinars tab under the About MCPAP menu item. We are going to stop the presentation for questions at several points, and we'll also leave time at the end for questions. If you have a question or comment, please type into the question box during the presentation. We'll read out the question or unmute your line to enable you to ask your question verbally. At the end of the presentation, you'll get a brief survey, and we'd really appreciate if you could feed us feedback so that we can continually improve our program. I'm going to go ahead and introduce our speaker. Our speaker is Dr. Bruce Waslick. Bruce is the Chief of Child Psychiatry at Baystate Medical Center, and he's an Associate Professor of Psychiatry at UMass Medical School. He attended Tufts University School of Medicine and did his training in child psychiatry and general psychiatry at Tufts New England Medical Center. He also completed a research fellowship in child psychiatry at Columbia University. And prior to joining us at Baystate, he was on the faculty at Columbia until 2005. Bruce has a remarkable history of accomplishment in clinical trials research, and he was the principal investigator for the Columbia site for the landmark TADS study on the treatment of adolescent depression. And he was also actively involved as a co-investigator on the CAMS study, which was a major multi-center trial for the use of SSRIs in anxiety disorders. He's been at Baystate for coming on 13 years, and he is the medical director for the West Central Baystate team in our new configuration. And we're really delighted to have him and appreciate his willingness to give us this presentation for today. So Bruce, go ahead, and we're looking forward to your talk.
Well, welcome everybody, and thank you for that terrific introduction, Barry. So today I'm going to basically talk about the run of the new MCPAP pediatric anxiety algorithm. We started the rollout process 2 months ago with the depression algorithm, and we've trained our staff here, and hopefully people are starting to make use of it out in the primary care world. And there's going to be some similarities in terms of the presentation today as there was 2 months ago. I'm going to do a basic introduction to the idea of the algorithms and how they got formulated, and then we'll jump into the algorithm for pediatric anxiety disorders itself. And I will say that this is not to be specifically relevant to OCD. OCD is a bit different, so we can call this non-OCD anxiety disorders. And in fact, in DSM-5, OCD has been removed officially from the anxiety disorders because there are some different elements to it. But why don't we go ahead and move to the first slide. What we're going to talk about is just a reintroduction to the idea of MCPAP clinical algorithms and why we think they're a good idea and how we think they're going to be useful for people working in primary care. We're going to the details of the MCPAP pediatric anxiety clinical algorithm, And then at the end, we should have some time for any kind of questions, comments, or discussion. We'll save that for the end. Next slide. In terms of presenting some of the initial work related to the clinical algorithms, the purpose, really the idea behind it, was to create a set of practical clinical guidelines for primary care docs when dealing with common mental health problems. The whole idea behind MCPAP is to help primary care providers get involved with their patients at the level of understanding their mental health as part of their overall general health. And we all feel that mental health is an important component of that. We've been at this now for several years, but we got to the point where we thought some practical clinical guidelines for the common mental health problems get down on paper would be helpful for everybody. So the guidelines will encompass real practical things like screening procedure recommendations. And then once somebody is done with screening, moving on to the evaluation process and the evaluation procedures. Once the evaluation is completed and we've got a pretty good formulation of what's going on with the child, we are also going to give some recommendations regarding treatment planning, and particularly relevant to primary care doctors will be the medication treatment guidelines. So I hope that all primary care providers will be involved and what's going on with all aspects of the mental health care, but you could be very much involved with the medication treatment for particular cases. Next slide. Next slide.
Bruce, I'm advancing the slides, but there seems to be something wrong with oh, it came up. Good.
Okay. Here we go.
Yeah.
All right. So we'll make sure we stay on track with this. So the MCPAP clinical algorithms, again, in general, the type of content that we're thinking about is content is really developed at the level that we think is going to be most helpful for the primary care provider in regular primary care practice. This is not guidelines for child psychiatrists or child psychopharmacologists, or it's really meant to be at the useful to primary care provider working in regular primary care practice. Content includes procedures that can be performed in all algorithms in the context of regular primary care practice. So this is not devoted to specialty care or developmental pediatrics. This is regular primary care practice. The content recommends the use of standard, well-validated clinical rating scales that can be used in primary care practice. All of the guidelines have been developed with some level of measurement-informed care, using scales that are generally available, good psychometric properties to help inform clinical treatment. So that's a commonality you'll see of all the algorithms that are coming out from the MCPAP clinical algorithm projects. And number 4, the content recommends the use of medication guidelines, setting evidence-supported first-line medication treatment for mental health conditions commonly treated in primary care. And we'll talk about this more as we go along, but we're not necessarily talking about treatment of very complicated, multiply comorbid cases or cases that have very severe features, or even cases that have treated with a lot of different approaches before, so what we would call treatment-resistant cases. Those are not the cases that we're focusing on with the clinical algorithms. It's really more of the type of cases that we would really expect primary care providers to try to treat in primary care practice. So the process of developing the MCPAP clinical algorithms, just to go through that briefly, the content is developed through the clinical consensus process of the MCPAP medical director's leadership team. So we've worked these over from our leadership team at MCPAP. They're really good content to be sharing with the primary care providers. The initial guidelines for the different at least our first several algorithms were developed by Heather Walter and her colleagues at Boston Children's Hospital for use in the PPOC practices. So that was kind of a starting place for us. I feel like we had to reinvent the wheel for the MCPAP clinical algorithm. So we've based some of the initial work off of Heather's work. And so some folks who are in the PPOC practices may recognize some of the features of these algorithms. They may have been exposed to components of them. But we've reworked them and we've developed them to really reflect the thinking of the MCPAP leadership team. First three clinical algorithms that are going to be rolled out are the depression algorithm, which we presented 2 months ago. Today we're talking about the anxiety algorithm, and the next presentation will focus on the ADHD algorithm. Next slide. So in terms of the applications, it's really meant to help train primary care providers in basic evidence-supported tools and procedures. Again, not for the really severe, complex cases, but for the mild to moderate, relatively uncomplicated forms of mental health problems that can reasonably be handled in a primary care practice. Some other applications, though, are really to try to help the MCPAP consulting teams provide consistent training and guidance to primary care providers during phone, face-to-face consultations across the state. So part of our goal is to provide some consistency in terms of primary care doctors interacting with the MCPAP teams. And if somebody is asking for either a face-to-face or phone consultation regarding anxiety or depression in the southeast part of the state, they're going to be exposed to the same type of procedures and recommendations that you would get if you were talking to somebody in the western part of the state. So it really is part of the idea here is also to try to give a certain consistency in terms of the consultation what we're doing through MCPAP. The algorithms will not likely be the best starting point for the severely ill, treatment-resistant, or high complicated presentations of mental illness in primary care. I think we've always worked on under the idea that those cases who are more severe, treatment-resistant, or highly complicated are probably best cared for in specialty care. And that's easier said than done, but I think that's a general idea of the program. The algorithms will be focused on the type of presentations you could reasonably expect it to care for in the primary care setting. And even though we're going to provide an algorithm here for folks to use, we really encourage the primary care providers to make liberal use of the MCPAP phone consultation and face-to-face consultations for complicated treatment-resistant or severely ill presentations, rather than relying primarily or exclusively on the MCPAP clinical algorithms. Be the case for all the clinical algorithms that will develop through MCPAP. Next slide. Okay, so we're going to jump into the MCPAP anxiety clinical algorithm. Again, it's the second clinical algorithm that we've rolled out through the MCPAP program. There's basically four major areas we're going to cover in terms of the clinical algorithm. The first is to provide a set of clinical guidelines for primary care docs in terms of screening for anxiety disorders in children and teens. Second is to provide some overview of appropriate diagnostic evaluation procedures. Once the evaluation's completed and we can formulate the case, we're going to talk a little bit about treatment planning considerations and who should be treated in primary care and who should be treated in specialty care, and how do we collaborate with psychotherapists. The fourth big area is to talk about medication selection, management procedures, again, that from the perspective of a primary care provider. Next slide. So the guideline, this is the format. It's on one sheet of paper. What you see as we kind of develop these, we're actually going to develop clinical pearls associated with each of the guidelines to go and dive in a little bit deeper in terms of different sort of clinical procedures and what to think about as we're going through the different areas of screening, evaluation, treatment plan, treatment. I want people to get too hung up on this because we're going to go through each of these parts in detail, and this might be a little bit small to read. But we want to give you the sort of general format of it. And if we go to the next slide, it breaks down the different areas that we're going to be focusing on. At the top is going to be the screening and evaluation procedures. We have some content related to the clinical decision making, which we'll walk through, and then we have a significant amount of work attending to medication selection support, and also how to follow up kids if we get them started in treatment. How do we follow up their care? How do we monitor how well they're doing? And when do we start thinking about ending treatment? And all that's going to be covered in the follow-up and monitoring support. So we'll go each of these in detail. Next slide, please. The guideline at the bottom is the reference acknowledging the origin and the process of development. And next slide, a big thank to the initial work from Heather Walter, the Department of Psychiatry at Boston Children's, and also all the adaptation work that we've done with our MCPAP medical leadership team. So thank Heather, Department of Psychiatry, and our medical leadership team. So getting into the algorithm itself, so we want to talk a little bit about screening and evaluation procedures. So we're sort of, the starting point for this is that a child's going to be brought to the primary care for a health visit. That we sort of have made a assumption that we're doing screening for mental health issues and behavioral health concerns at child visits. We can also, sometimes some of the kids are going to be brought to the pediatrician with significant mental health problems, not necessarily just at the time of their their child visit or their health maintenance visit. There'll be other times in between visits that a significant current concern is going to be developed. So, but we're seeing at the point of screening for behavioral health problems. We've generally recommended for our first two algorithms that the pediatric symptom checklist, SC17, is a really good screening to be administered at the child visits. It gives information on a variety of common mental health problems that you might see in primary care practice. So we're going to use that as our screening tool, the one that we're recommending through MCPAP. And once we do screening, we're going to move over to evaluation. So if we go through the screening and the evaluation we conclude that there's a concern for subclinical anxiety, and we're going to take an active treatment role. We might monitor them monitor the kids with guided self-management and with follow-up. If there is concern for clinical anxiety, then we want folks to be conducting a focused assessment, looking at precipitating factors, using the symptom rating scales, getting a sense of whether there is a family history of anxiety or anxiety problems in the family, and also assess for red flags. We'll talk about the red flags in a minute for medication use. And of course, if there is any concern associated with the initial assessment for imminent danger, and we need to refer to a crisis evaluation or to a emergency psychiatric assessment for the cases that are presenting with any kind of emergent concerns. And, truth be told, anxiety or severe anxiety can lead to psychiatric crises. Some kids experiencing severe anxiety can experience suicidal thinking and even engage in suicidal behavior. So it's a risk factor for psychiatric crises. If the screen is positive, we're going to do we're going to recommend conducting a brief review on distress, impairment, danger, and then sorting out from the evaluation what the level of anxiety is for each of the kids, and come up with some appropriate treatment planning from there. And again, of course, if you ever have any questions, make sure you make use of the MCPAP consultants by phone. to answer any particular questions. Next slide is really presenting the pediatric symptom checklist. And we recommended this as a screening tool for depression as well, but a couple of issues with this using it as a screen for anxiety. See on the left the different sort of levels of concerning symptom scores. So when we're talking about anxiety and depression, psychiatry, we often refer to those as internalizing symptoms. And at this level, where there are particular items that are going to be the internalizing symptoms items. So 2 feels sad and unhappy. Number 6 feels hopeless. Number 9 is down on him or herself. Number 11 seems to be having less fun. And number 15, which is worries a lot. Now, if you're following along those items, those 5 items make up the internalizing symptom subscale. Any one of those, number 15, actually targets anxiety in and of itself. So, you know, the 4 symptoms are much more related to depression. Sometimes anxiety and depression go together. Sometimes depression occurs without significant anxiety, and sometimes anxiety occurs without significant depression. So this screening scale is biased toward picking up depression. But there is the item 15, which is worries a lot, and that will correlate fairly well to kids with what's called generalized anxiety. So we're also recommending when kids are scoring positively on the internalizing symptom subscale, that in general that the primary care doctors are also best recommended to supplement with a couple of other screening questions for anxiety or fearfulness beyond just worrying. So are kids nervous a lot, or do they get nervous in certain situations? Questions like that, just to kind of make sure that we don't miss the kid's anxiety. So I think that in general we can use the PSC 17. It's the degree which it covers anxiety is probably not as strong as we would like it, so that we would recommend supplementing your screening with maybe some free-form questions to the child or to the parent, or both, around other symptoms of anxiety. And this is just sort of illustrating the item on the PSC 17, number 15. That's the one that gets at the specific anxiety problem. But we should be doing some additional questions when kids are coming up positive on the PSC 17 internalizing subscale. Next slide. Okay, once we've got a positive screen, it's time to move into evaluation. So we've included some procedures and some tools to help primary care providers with the evaluation process. Again, we had a similar approach when we were looking at depression a couple months ago, but the same thing. So we want, and we'll flesh out some of the more details about the evaluation using the clinical pros sheet as this becomes available. But we want pretty good evaluation. So for an initial assessment, you want to interview the child, you want to interview the parent, get a history of the symptoms, talk about any kind of recent precipitants, you'll probably have a pretty good understanding of the child's basic health concerns and developmental issues just because they've been in the practice, hopefully. But we're also recommending that for the kids screened positive to administer evaluation tool that I think we feel covers the anxiety, the spectrum of anxiety problems that would be interested with this algorithm is called the Screen for Child Anxiety-Related Disorders, or what is commonly referred to by the acronym SCARED. SCARED is a really excellent tool. There's a SCARED form for the parent to fill out. There's a SCARED form for the child to fill out. It really covers, and I'm only showing here the first page of it. It's a 2-page screening form. Pretty easy to understand, pretty easy to fill out. It's been empirically validated as an assessment instrument for between the ages of 8 to 18. And it also, we'll see on the next slide, I don't want to go there yet, but we'll see on the next slide, it helps to break down what areas of, what types of anxiety kids are experiencing with the different questions. So it will, you'll be able to evaluate it using subscales to sort out whether the child's suffering from a generalized form of anxiety, where they're worrying all the time and feeling nervous in a variety of different settings and situations, or something like panic disorder, where they have acute panic attacks, and between the panic attacks, they may have some anticipatory anxiety of panic symptoms, but they may be experiencing as much generalized worrying. So this scale will help break down and help us understand exactly what kinds of anxiety disorder the child may be suffering from. We're suggesting that the GAD-7, which is commonly used for assessing adults with anxiety, can be used in this age group as well, especially for kids where we are worried about generalized anxiety. The G7 has been empirically validated for kids at the ages of 12 and above. So it's not a great tool for the younger kids, but for the kids who are 12 and above, there is some empirical support for using it, both assessment instrument and also an instrument that you can follow longitudinally for signs of improvement or change. So either of the tools, again, the SCARE is going to cover more ground with more forms of anxiety problems than the D7, but either of the tools we feel comfortable recommending in the primary care practices. Some of the things we should think about is that all responses that are put on paper by the parent or the child should be verified by a primary care practitioner to make sure that, you know, kids have given it adequate attention and the parents understand the content and things. So make sure you go over it and make sure, you know, you can say, you know, you're indicating here that you have a lot of what we would call anxiety, and make sure that we're on the same page with that. A reminder that the diagnosis of any definite anxiety disorder also requires symptoms, in addition, some degree of severe distress or impairment of functioning. Kids are reporting symptoms of anxiety, but they're any distress or impairment of functioning, that's not going to qualify for an anxiety disorder. Anxiety disorders, clinically significant, are usually causing major issues with distress and also impairment in functioning. And there are important rule-outs, you know, as you're doing an evaluation. So an adjustment reaction is different. So you can get an adjustment reaction, which would be an acute reaction to some sort of stress in the environment, which may be causing anxiety, but usually time limited, and it's probably better to deal with the acute stress than to set up a treatment program for an anxiety disorder. I think they're different. Acute stressors in the environment certainly can cause anxiety reactions, but we do try to separate those out from anxiety disorders. And if you need any help with that, sometimes that's a good consultation question for the MCPAP consultants. Want to find out whether the kids are also suffering from any kind of mood disorders. We would certainly make sure that they not experiencing any medical disorders that can lead to symptoms compatible with anxiety, such as, you know, hyperthyroidism can make kids look very anxious and feel very revved up. Again, we wouldn't want to treat somebody with hyperthyroidism for anxiety. We would want to treat their hyperthyroidism. Reactions to medication. Some folks do respond anxiety and reactions as an adverse reaction to medication treatment. So we want to make sure that no recent medications might be causing the symptoms. And of course, for the older kids and teenagers, we would be important to make sure they're not involved with any active abuse of illicit substances that can also present with symptoms that resemble anxiety. Slide. So yeah, GAD-7, and just you know, you can kind of go through it. It's not very time-consuming to fill out, and it's going to assess symptoms over the last 2 weeks. Easy to score, easy to add up. So I think, again, this would be another alternative measure to be used, especially for kids where we think the anxiety is related to the generalized anxiety disorder as opposed to another type of anxiety such as anxiety disorder or separation anxiety disorder or panic disorder or any other of the other anxiety disorders. Next slide. Again, we talked about the SCARED. The SCARED has a scoring interpretation that is often available right on the form if you've got the right form. We generally consider a score of greater than or equal to 25 to be positive in terms of the presence of an anxiety disorder. Scores higher than 30 are more specific, so 25 to 30, you're kind of in the concerning range, and 30 and over, you're probably dealing with at least one anxiety disorder for that particular child. And if you go through the different items and score them, you can get subscales. So we have a subscale for panic disorder or significant somatic symptoms associated with anxiety. We subscale for generalized anxiety disorder, a subscale for separation anxiety disorder, and a subscale for social anxiety disorder. The SCARED also screens for significant school avoidance. And those cutoff scores for each of these subscales get you directed toward the specific types of anxiety the child may be experiencing. So these total score cutoffs as well as the subscale cutoffs are available both for the parent-rated form as well as the child-rated form, and then empirically validated. So it makes for a very good assessment tool. Next slide. The D, which people may be familiar with some of the adult work, the empirical research here is a little bit different than adults. For adults, the cutoff point for clinical significance is 10, and scores indicating 15 or higher are considered severe anxiety. For kids, a little different. So for the cut point for youth is 11 or higher on this scale. The research suggests that we would go with a cut point a bit higher than the adult cut point. So we're looking at 11 or higher as being positive, and 17 or higher on this scale for kids would be considered on the severe end. Bye. All right, so we talked about screening and we talked about evaluation. So once we've got all the information sorted out for the evaluation, it's time to think about some clinical decision making, and we've given some guidelines in terms of the algorithm for this. Again, for the diagnostic evaluation, we would also take a look at how severe the anxiety is, because the anxiety severity is going to help us do some planning related to clinical decision making. And so in addition to the anxiety severity, we're also going to look for red flags or diagnostic rule-outs that could be expected to affect treatment planning. So the red flags that would affect your decision making would be indication that the child is experiencing significant suicidality, and that is generally considered to be more of a psychiatric emergency. So we're not going to move into sort of an ambulatory care treatment algorithm for somebody who's suicidal. Suicidality has to be taken seriously. Anxiety is a risk factor for suicidality. So if the indicators of significant suicidality, then we probably have to refer those kids for emergent assessment by a specialized provider like a psychiatric crisis service. Again, some people presenting with psychosis can present with a lot of anxiety, but if we have elements where being delusions or hallucinations of any type, auditory hallucinations, visual hallucinations, psychosis again is related to probably more of an urgent situation, and probably need to get those kids going with treatment really quickly. Maybe best referring anybody with significant psychotic symptoms to emergency psychiatric assessment. Those kids might need more urgent care at the level of an inpatient unit or a partial hospital assessment. Trauma, extensive trauma, especially recent trauma, probably we're not going to enter those kids into an ambulatory care treatment algorithm. those kids are going to probably need much more specialized, probably have to be referred for either further MCPAP consultation or more specialized care. And again, kids with significant levels of substance abuse are not going to fit into this algorithm. Those kids are going to need more specialized care, either through a specialized substance use facility and may need some further assessment. Those are the red flags to watch out for. So those kids, if we got significant red flags, we're going to not follow the algorithm. We're going to get those kids more specialized and potentially urgent care. And again, when we're doing the assessment, we want to make sure that we are treating an anxiety disorder, not an adjustment disorder or medical disorder or substance abuse or reactions to medications. Those can follow the algorithm here. They should be referred for different types of treatment. If you have any questions about the diagnostic assessment, I think it's certainly when contacting the child psychiatrist on call to discuss any concerns that you have through the MCPAP program. Next slide. Treatment planning, we're going to move to. So subclinical to mild anxiety, again, probably doesn't necessarily warrant a specific treatment. Self-management with follow-up. Moderate anxiety or if the self-management is not successful with the mild anxiety, then we make referrals for therapy, and then in our algorithm, we are suggesting if we find it, CBT in the community. CBT's got a very good track record. That C means cognitive behavior therapy, is a very good track record as being very safe and effective for kids suffering from anxiety disorders. And medication is on the table at that point if we're dealing with moderate anxiety. Severe anxiety, again, we're thinking is going to be more likely referred to specialty care for CBT psychotherapy and more specialized medication management, at least until they're stable. Then they may return to primary care for ongoing care. Next slide. So medication selection. So there is and I don't want to draw too much attention to it, but there is an FDA-approved medication for the treatment of a non-OCD anxiety in kids, and that is duloxetine or Cymbalta. We are not recommending that, even though it's FDA approved. It's got an FDA approval on it. We are not recommending it as a first-line agent. The evidence base is much stronger for the use of SSRI treatments at this time. And the two that we think are reasonable first-line treatments are sertraline and fluoxetine. We'll see from this treatment algorithm, we're a bit more conservative in terms of our dosing guidelines for kids with anxiety as opposed to depression. And it's because some of the empirical research suggests that kids with anxiety may experience a bit more sensitivity to SSRIs. So we're a bit more cautious in terms of the dosing algorithm, even for the older kids. So we're recommending to start with a daily test dose for 1 to 2 weeks, fluoxetine at a dose of 5 milligrams or sertraline at a dose of 12.5 milligrams. If the test dose is well tolerated, they can go ahead and increase it. It's unlikely that most kids are going to respond to treatment at this level. We're probably going to have to push the dose up, but we want to make sure that the kids are tolerating it well. So we start with low doses and then increase the test dose as long as we know it's tolerated to a dose of fluoxetine 10 milligrams or sertraline 25 milligrams. The general caveat being start low, go slow, adjustments no faster than every 2 weeks. We're going to monitor the kids fairly closely for any evidence of agitation, suicidality, severe side effects. Especially, these are the medications with the FDA black box warning, and that has been for kids, regardless of whether you're treating them for depression or anxiety, the black box warning is in play. Fortunately, these type of treatment-emergent suicidal are very rare, but we do have to monitor for them fairly closely. And if there's any concerns about this, make sure you consult with the MCPAP child psychiatry team. Slide. Usual therapeutic dose for youth with non-OCD anxiety disorders. In fluoxetine, it ranges on the low end for 10 milligrams, the high end 60 milligrams. sertraline on the low end, 25 milligrams, to the high end, 200 milligrams. Evidence-based information suggests close monitoring during the initial phases of treatment, with suggested dose escalations every 2 to 4 weeks based on two things. One is medication tolerance, any evidence of side effects, and the second is therapeutic response. It's not a good idea to try ahead and increase the dose of medication if the kid's experiencing some ongoing side effects that we think are related to the medication. Some side effects will just subside with prolonged exposure to medication. If they're showing any signs of intolerance, don't increase the dose. Wait for the side effects to subside. If they don't subside, we might have to think about a different medication treatment approach. We do think it's a good idea to give considerations to what we call PRN medications for breakthrough or acute anxiety, recommending the use of mild, non-controlled substances such as antihistamines, hydroxyzine, 5 to 25 milligrams for ages below 12, 25 to 50 milligrams for ages 13 and above, not to exceed 2 doses per day. So this is, especially in the first few weeks, if the kid's having a severe panic attacks or anxiety symptoms that become unmanageable while we're waiting for the SSRI medication to improve things, you can consider giving something like hydroxyzine for those acute periods to help the kids calm down. It's very safe. The biggest side effect tends to be sedation. So families have to be warned about that, but in general, it's generally safe. We're not recommending routine use of benzodiazepines. In fact, we're only recommending that benzodiazepines for acute anxiety be recommended after discussing with the MCPAP child psychiatry consult. We don't generally recommend benzodiazepines for the kids. There are some other better alternatives. It doesn't mean we would have an absolute prohibition. There are certain kids in my practice I have benzodiazepines, but it's actually a very small number. Next slide. And then just finish up with the follow-up and monitoring support. So after 4 weeks, we're going to reassess the symptom severity with either the SCARED or the GAD and compare the scores on the scales, their baseline scores. If we're making progress, we should see improvement in the scales, and the score would go down. If the child remains significantly symptomatic, we're going to consider increasing the dose of the medication, pushing fluoxetine up to 20 milligrams or sertraline up to 50 milligrams, then monitor again for how the kids respond to those medication changes. At 8 weeks, we'll do a reassessment again. Score remains above the cut point and impairment persists. We can again consider additional doses in the medication, increases in the medication, fluoxetine 30 milligrams or sertraline 75 milligrams. We'll follow the kids pretty closely, make sure they're monitored for other side effects. And again, along the way here, if we're running into any sort of complicating factors, you should feel free to consult with the MCPAP team. In general, we're suggesting that if distress and impairment are severe, you can increase the fluoxetine dose by 10 milligrams every 2 weeks, sertraline dose by 25 milligrams every 2 weeks, and kind of keep how the kids are responding and how they're tolerating. If the distress and impairment score remains relatively unchanged after extended treatment, or youth remains severely affected with no treatment response, then consider, calling the MCPAP team for a phone consultation or even a face-to-face consultation at that time for evaluation of the diagnosis. There may be some other issue going on, a comorbid psychiatric disorder that's impairing a child getting better. So if we see the type of response we want at 8 weeks, 10 weeks, 12 weeks, consider contacting MCPAP either for phone consultation or face-to-face consultation. Next slide. Again, going out to 12 weeks, we're going to reassess with the SCARED, the GAD-7. If we're at 12 weeks and we're not seeing much of a response, it's a good time to space with the MCPAP team. We're going to monitor monthly for the kids who are doing well, to make sure that if they're doing well, that they maintain they're doing well, the remission remains in remission, for any side effects, and then consult with MCPAP as needed. Next slide. Okay, if we are successful and the kids respond well to the treatment, either the medication, the CBT, or the combination, or the other forms of psychotherapy, if we have a good response and the child remains in remission for a prolonged period of time, and are recommending approximately a year after medication, then to reassess the symptom severity with the SCARED and the GAD-7. If score is below the cut point without impairment, then it'd be time to terminate treatment. So they were going to recommend decreasing the daily dose of the medication every 2 to 4 weeks, monitor the kids through this process to make sure that the symptoms don't recur. We start as we go through the treatment termination phase, and if everything goes well, the kids may be able to discontinue the medication, again, some level of monitoring after the medication's been discontinued for a period of time to make sure we don't either have a relapse of symptoms or a recurrence. And if there's any sort of issues or concerns related to this part, which is the treatment termination, feel free to make liberal use of the MCPAP consultants to help guide questions or concerns. Next. Just to review, so this is the review of the clinical algorithm for the anxiety. The algorithms, again, are not going to be the best starting point for the severely ill, treatment-resistant, or highly complicated presentations for anxiety in primary care. Any things that come up or any questions or concerns or things that go a little different than what you expected, maybe you make liberal use of the MCPAP phone consultations and face-to-face consultations, especially for the complicated treatment-resistant or severely ill presentations, as opposed to relying on the MCPAP clinical algorithms. Next slide. Okay, I think we're all set with my presentation, so thank you for your attendance, and we would at this point welcome any questions or comments.
Bruce, thank you so much, Bruce. We have a few questions that we've received, and Jim's going to go ahead and read them, and we can hear what you have to say.
Bruce, first question is about the JD7. What about using it in 9 to 11-year-olds? Are there particular problems?
Well, I think the only problem is it hasn't been really empirically well validated with the 9 to 11-year-olds. So we've tried to stay with guidelines that are evidence supported. So I'm not saying you can't use it, it's just not an evidence supported use in that age group, and there may be particular limitations, especially for some 9-year-olds, that are hard for them to understand the questions. I think you can cover the same ground with 9 to 11-year-olds by using the SCARED. The SCARED's a little bit longer, takes more time, but with the younger kids, at least we have an empirical validation of it. So for the kids below 12, we're recommending the SCARED, and 12 and above, the SCARED or the GAD-7.
Hey, I would mention just that it isn't understandable kind of which to use the GAD-7 just because it is a lot easier. It's short, it's easier to score. The point is well taken and important that it's not validated, but I think that the validation has more to do with the scoring and what the significance of the scoring is, in terms of sensitivity and specificity, as opposed to use it as a tool for kind of following patients in terms of their overall progress. And so you might, some people might choose to use, we're not recommending it, but if people chose to use the GAD-7 and really kind of thought of it as almost like a history-taking tool as opposed to a test, that would not be, in my opinion, reasonable, especially if people are finding the SCARED to be kind of cumbersome to use as a repeated measure, given the length of it and the complexity of it, in the primary care setting.
Thanks, Ray. The question is a question about trichotillomania, and do you treat that more like OCD, or can you use that anxiety? Can we use this anxiety algorithm for that?
Actually, my opinion about trichotillomania, it gets into probably a different category of mental health problem, probably more connected to OCD. Certain habits that have been developed, a variety of different sort of habit-related mental health problems like skin picking and trichotillomania and things like that. They overlap. Most of the time, I think if I was prescribing a medication, a first-line medication for a child with trichotillomania, say they haven't responded well to sort of general supportive things or psychotherapy, I'd be thinking about the SSRIs, because we know the SSRIs are first-line treatment for the OCD-related problems. So I think that there are some components from probably a neurobiological level that overlap with anxiety, but it's a bit different, when you get into the kind of the habit or the OCD arguments, and hopefully we'll be dealing with those in further algorithms. But if we're thinking about a medication, we probably use similar guidelines to treating trichotillomania with SSRIs as we would be recommending in the pediatric anxiety algorithm.
You mentioned that some medications may cause anxiety. What particular ones were you thinking about?
I'm trying to think. So I've seen some kids who've gone on steroids for some reason who start presenting with anxiety. It's interesting that some kids who are treated with stimulants for ADHD react with significant anxiety symptoms. You occasionally get paradoxical reactions of anxiety with antihistamines or things like that. We could probably go through a list of different types of medications that, in rare situations, probably more related to individual constitutional factors, an atypical reaction to a medication. But there are probably other medications that people can think of where they say, oh boy, this child seems like they're having an anxiety reaction, and is it related to the medication that was prescribed for a completely different process? Ones that come to mind are steroids, sleep medications. I don't know, Barry, can you think of any others that?
I think a big one is that's very common is pseudoephedrine.
Yes.
Decongestants, and kids with epilepsy. Keppra is an example of one that can cause mood and anxiety issues as well. But I think the pseudoephedrine is probably the most common one I can think of.
That's a good point.
But in general, Bruce, if someone has just started a medicine and they have a symptom they haven't had for a long time, you got to be suspicious that they're related.
You got to be suspicious. Yes, exactly. I agree.
So what about switching medicine? If you choose, whether you choose the sertraline or the Prozac to start with, when do you consider switching to the other?
Well, if we're seeing nothing at 6, 8, 10 weeks, if we're seeing no response with some medication dose adjustments and they're tolerating the medication well, we think their compliance is good, but we're really seeing nothing in terms of symptom improvement, I would probably be thinking, 8 to 10 weeks is a good time to make a change. If we're seeing some improvement there's different patterns of response. So if we see some improvement with some dose escalation, that at least encourages me to proceed with further dose escalations to see if we can kind of get a significant improvement with sustained benefit. Sometimes, you see really dramatic improvement in the first few weeks, either after starting a medication or a dose change, and then the kids go through a period of what's called poop out. It's like all of a sudden it's not working as well. Symptoms are back. They've had breakthrough symptoms. In situations, I would continue to increase the dose as long as we aren't having any negative side effects, because sometimes what happens is once you increase the dose, you recapture the response, and eventually you can get to a dose where response is good and it's sustained. That's the key, is that you don't want to just improve things for a couple of weeks. You want to see that the response is sustained. But if you no response at 8 to 10 weeks, or you're getting real issues with side effects and tolerance, I think, it's time to make a change. In general, I would say that most people would recommend a switch to another SSRI. The first SSRI has not been successful. So you start with fluoxetine and you get nowhere. You switch to sertraline. Sometimes you pick up kids who respond to the switch, the change in the SSRI. You've gone through 2 treatment trials with fluoxetine and sertraline and really not getting anywhere. Again, then you're in the treatment-resistant category, and those kids probably need to be referred to more specialized care or at least a MCPAP face-to-face consultation.
Thanks. One question that person says that with large adolescents, he started with a higher dose of either sertraline or fluoxetine. What do you feel about that?
In general, I would say that the body size has an effect in terms of tolerance and response, but it's not a clear correlation. We've been conservative in terms of our dosing guidelines, and actually we're a bit more conservative in the anxiety dosing than we were in the depression, because we actually took into account not body size but age as a factor in terms of determining initial dose. I agree actually with the person who made the comment that sometimes I've started with higher, especially if I think a kid is really severely impaired. I might be more aggressive. For a teenager, I might start at a higher dose. There's a lot of factors that go into that judgment. So I think it's a judgment call to some extent. The guidelines here are probably geared a little bit toward trying to avoid reactions. For people who are very anxious, if you prescribe a medication and they get a side effect from it, they will just increase the anxiety and may generalize to concerns or anxiety about medication treatment in general. So there's a lot of good reasons to be cautious initially, especially for people who've never tried medications, to avoid side effects initially. But there have been times in my specialty practice where I might do more aggressive dosing if I think the symptoms are very severe and very impairing. And I didn't want to wait, several weeks before we get up to doses that I feel like are going to be helpful. It's a judgment call, but the guideline is really taking a conservative approach to try to avoid intolerance in the first few weeks of treatment.
What I think we'll have time for is following. With mild anxiety in a high school setting, would group therapy be appropriate rather than individual therapy?
Anxiety disorder, from a psychotherapy standpoint, this is probably based on my experience in CAMS, the format of the group or the individual is really less important than that kids are learning, cognitive behavioral techniques in terms of coping with anxiety. I'm aware that CBT has been modified to group settings. The big issue for me from a psychotherapy standpoint is to help kids understand the difference of avoidance as a coping skill versus more of a face your fears kind of thing. And we try to help kids not avoid things they're anxious of, but learn coping skills so they can deal with the different issues and settings. So I think that if a group is really helping kids develop tools, managing anxiety in an appropriate way, and decreasing the use of avoidance and increasing the use of trying to figure out ways to kind of face the things you're anxious about, I think it's okay. I think it's the skill set that's being taught in the group, probably than the format or the whether it's an individually delivered or group format. But I'm a big, having seen kids and worked on the CAM study, the Coping CAT CBT protocol, helping kids with anxiety. I've just seen some real improvements with it. So I would love to see most kids get involved with CBT for anxiety, whether it's individual format or group format.
That's a nice point, Bruce. I would add that pediatricians and child psychiatrists often get asked, by parents about kids special kind of accommodations at school where they get excused from certain activities that they're nervous about. And it's counterintuitive, but it's really important to avoid kind of supporting those kinds of recommendations and to teach people, why you're saying that. You need to balance, being supportive with CPT principles, because we don't want the kids to get flooded and overwhelmed. But the more that they are excused from things that make them nervous, the less opportunities they have for exposure, which is really the active ingredient of CBT. So that's kind of a tip. I think we'll include that in the clinical pearls when they're finalized. Unfortunately, we're out of time, and I want to thank Bruce for a really excellent presentation, and I want to thank everyone for attending, and we'll look forward to seeing everyone next month.
Thanks, everybody.